Hello and welcome to the multi-level health information modeling tutorial series.
Coming back to the issue of semantic interoperability, why is this required in healthcare and it's not required for mostly any other sectors of society? What happens is, if you think about any other type of consumer profile, what happens to you in one given place doesn't affect what will happen to you in another place, even if you are a customer of the same type of commodity or service in both places. I'm giving you a very simple example. You can go to gas stop 1 and fill up your tank, and they'll probably have a system there where they're going to collect the information about what happened to you when you were there filling up your tank. How many gallons or how many liters and how much did you pay, and basic information. And then another day you go to gas stop B to fill up your tank, and they will have a system. And it's not a problem if the system is developed by another software company or not, or if it's an older version of the same software developed by the software company that deployed the system at gas station A. It doesn't matter. The fact is that what happened to you in gas station A does not affect at all what happens to you when you go to fill up your tank at gas station B. In healthcare, that never happens. In healthcare, everything, even in the most remote past, is connected. What happened to you when you went to the primary care setting is critical to define what's going to happen to you when you go to the hospital. Sometimes what happens to you 5 years ago in another hospital will be critical to define what will happen to you in this hospital. The classical example is when you have a medication allergy. This medication allergy was discovered 5 years ago in a given hospital where you lived, but now you moved to another city, and you're going to a hospital for another reason, and you don't remember, or maybe you were not even informed about this allergy. That happens frequently. And then you're gonna receive a certain treatment in this second hospital, and they are not aware of the fact that you have a medication allergy. And they might or might not give you this medication that you're allergic to. But see, if they did have this information, that might change the conduct of this hospital completely. Or if you have a dog bite, if you were exposed to other dog bites before and you were vaccinated for rabies before, that changes completely what's gonna happen to you in this new accident. And so you can imagine, you can be here just bringing different use cases, and they will just keep coming on and on and on. So everything is interconnected in healthcare. The patients should be seen as one person, and their entire history of life and their entire history of healthcare is very important to define what's going to happen with this patient at every moment that this patient requires medical care again. And then what happens is that you start to hear the most amazing workarounds for this kind of problems. Oh, but the patient will tell. Some patients are very good informants, but some patients are not, because of their conditions, because of the fact that they have a neurological disease that affected their cognition, or they're confused, or they are distressed because they are in pain, or in the most critical moments of a patient's life, the patients will be unconscious, and the paramedics or the ER people will be there trying to perform a PCR or something like that. And what happens is that the patient is unconscious. The patient can inform anything. And if you have proxies around, if you have family around, it's very likely that this family members will be yelling and crying and desperated, and they won't be very informative. This is something that is very likely to happen. So relying on memories and relying on information from people who are emotionally involved in a certain situation, it's not the best source of information. And then, what are the workarounds that we see nowadays? It's very common that the record from a given patient, when this patient is going to be discharged, will be printed out, again, pieces of paper, for this patient to be responsible to go there and take that to the other healthcare setting where this patient is going to continue the treatment. And we know that this is not practical for many reasons. Okay, even if the patient shows up there in the other place with the complete report from the first healthcare setting, what happens is that the data model of the information system in the second healthcare setting might not be prepared to collect part of the information that came printed out. And so this part of the information will just be lost, the same way it would be lost if a certain piece of paper was not sent to the other place. And so you are losing a lot of context from this first encounter. A lot of context will be incarcerated in that first system forever, because the other systems are not prepared at all, if they are based in traditional modeling, to record all the context, all the semantics that was included in that system the first time. Or other things like, oh, but we can build a big system that will work on both settings. Well, at this point, I think I already made my point about the fact that a megalithic system that will take care of all healthcare settings is impossible. Even if you could have 310 tables in your system, and that would be useful for any place, you still can't reach consensus between all the experts involved. So this is not feasible. But the fact is, these and similar things that might work for other industries have been tried since 1961. That's the first report of an electronic health record that we know. And billions in dollars and euros and other currencies were spent, and it has not been working yet. Another issue is maintenance. Semantic interoperability is critical, but imagine that you are not concerned about this whole problem with exchanging data between systems. That what you want is to feed your family, building a self-contained electronic medical record, and you're gonna make a lock-in policy with one customer, and you will be very satisfied with that, and you don't want to think systemically because that's the way that you make your living, and this is too complicated. You just want to be there selling your software, not talking to any other software. This is not a problem for you. Okay, you still have a problem for your self-contained system, that is maintenance. In healthcare, the concepts evolve so fast that the data model that you define today will be outdated in, let's say, 6 months, depending on what's the medical expertise that is involved in your data model. For some areas, it's that fast, genetics and pharmaceuticals and all those things that have a lot of technology implemented, and the research is very active. Your data model is developed today, and you know in some months it's outdated, and your customer wants you to update it. And new concepts come along every day. They want to include those new concepts in your data model. And in traditional modeling, we know that means changing your persistent, changing your tables if you're doing something with relational databases, changing your graphical user interface. And this is not a simple process. What we know is the average time for a medical software to be abandoned is 2 years, and the abandon rate is 70%. The source for those figures is one of the Chaos report. So the consequences is that many and very expensive things have been proposed to solve the semantic interoperability and to reduce maintenance costs of healthcare applications. And in decades, let's say 3 decades, we still didn't have any evident results yet. In addition, you need to remember that healthcare is the most conservative sector of society. So if you talk to people in healthcare settings about workflow change, you have a lot of resistance, and adherence is very difficult. The results is that paper persistent is solid and is defended by a very considerable proportion of the healthcare professionals and other informal workarounds. It's very common for you to see there is a system, the system is mandatory, and lots of spreadsheets and other small databases are used around to collect the information that is really significant for that specific group of people in that specific healthcare setting. And on the other extreme of the healthcare policy makers, what happens is that they are so afflicted with the fact that nowadays there's this huge complaint about the quality of healthcare, and the fact that this whole idea about information technology will solve all those problems is the panacea. You need to implement it, and your problems will be solved, your healthcare system will work. And the politicians are very afflicted with that. And what happens is that lobbyists know about this affliction, and they knock at the door of the policymakers all the time, trying to sell their specific interest, their product, as the solution for all those problems. And the governments buy it because they are not very well supported in terms of technical advisory. And with that, hundreds of millions of all types of currencies are wasted. And then in the middle, software companies, serious software companies, they don't want to develop healthcare products because it is complicated and the clients are never satisfied. When you have problems with this level of complexity, you need to think outside the box. And here I have a box that is super psychedelic because the way that you need to think outside the box in this case should be very, very outside the box. To start with, let's think about what Albert Einstein said. Make things as simple as possible, but no simpler.